Our overarching aim is to give the reader all the necessary details to be able to replicate your study. So if somebody reads your methods and materials, you should be able to conduct the same study, following your protocol, and be able to say, okay, I followed step A, B, C, D that you said you did. You said you did a case control study. I've done the same thing. You said you did it in Kumasi. Okay, I've also done the same thing in Kumasi. You said that you took blood pressure this way. I've done the same thing. You said you measure heights this way. I've done the same thing. How different will my result be from yours if I follow the same steps? Or you say there's a lab technique that you have developed for, let's say, performing an assay. You've written the lab technique, step 1, step 2, step 3, step 4. Somebody taking the same protocol must be able to analyze samples and maybe get the same results. Okay, so your methodology must be done in such a way that anyone who picks up your protocol must be able to replicate your study. And usually it's broken up into about 3 key subsessions. The first one is that you have to present the study design clearly. Okay, there's nothing frustrating like reading the method set and you're not sure whether you're dealing with a case control study or you're dealing with a cross-sectional study. It's not clear. But you want that clarity because your findings and your discussions are going to be based on a type of study design you deployed. For instance, if you want to say that something causes disease, if you want to say that, let's say, smoking causes lung cancer, you have to deploy, let's say, a core study and follow people who have smoked over a period of time to determine how many of them have developed lung cancer to say that actually smoking causes lung cancer. You cannot say that smoking causes lung cancer by just doing, let's say, a cross-sectional study. Okay, you may be observing associations between smoking and lung cancer, but you may not be able to say that smoking causes cancer because just by virtue of the sort of study design that you have. So it's important that if you're writing a paper, you understand the diagram I've just showed. This diagram I'm sure is familiar to most of us. It just tells you the type of study designs that you have, either the investigator assigned exposures. In other words, is it an experimental study or an observational study? So usually experimental studies seeks to assess interventions and their effects. Okay, so you may assign the intervention to one group and withhold it from another group, or use the usual care for another group in a randomized fashion and then look at the outcomes. It's believed to be the highest level of providing evidence. Or sometimes to maybe a non-randomized control trial where an intervention is given to everyone and they are followed up for some time just to see what happens at the end of the day. And then sometimes too, you may have an observational study, and usually an observational study can be descriptive, purely descriptive, or analytical. And when it comes to analytical studies, you can have core studies where there's an exposure, as I mentioned, like smoking, and you're following people up to see the outcome, lung cancer. Or you can deploy a case control study design where the outcome is known and they're trying to measure the exposures that give rise to the outcome. For example, in our Syrian study, when we're trying to assess the risk factors for stroke among Africans, we recruited stroke cases and recruited stroke-free controls, and we measured risk factors, hypertension, diabetes, dyslipidemia, and the rest. And then we compared the prevalence or the occurrence of these risk factors in stroke cases versus controls. And then we're able to now measure effect sizes, odds ratio, population attributable risk, and so forth. And then of course, you can just do a cross-sectional study where you do a one-time study just to measure prevalence or frequency of events. So these, and of course, you can also have the qualitative study. So all these type of methods should be familiar to the one writing the paper, so that you don't say cross-sectional study when you want to actually say it's a case control study and so forth. And I think we covered this in our first series. And then when you're writing the methods, you want to describe the measurement parameters. For instance, how did you sample your participants? Was it a consecutive sampling approach that you use, or a non-consecutive convenience sampling approach, or participants were randomized? So your sampling technique must be clear. And particularly for clinical trials and even observational studies, you must tell us who qualifies to be in your study. What is your inclusion criteria? What is your exclusion criteria? And sometimes you have to justify why you are excluding some people. I recently reviewed one paper that's rejected. He said you're going to look at, hey, maybe let me keep quiet too. He said you're going to look at GGT as a risk factor for cardiovascular disease in hypertensives. You decide to exclude people who take alcohol. Alcohol itself can be a risk factor for hypertension. So if you take alcoholics out of such a study, you are biasing your study from the get-go. So inclusion and exclusion criteria must be carefully selected and reported. And then if you are doing a case control study, it's important to be able to describe how controls were, for instance, selected. So in our Sarin study, we recruited stroke cases, and we said that stroke cases had to have had a CT scan or MRI to confirm that they have a stroke. And then we said controls were recruited without symptoms of stroke, and we used a questionnaire, a validated questionnaire called the QVSFS, questionnaire for verifying stroke-free status, which we validated. And then if you score negative for all the symptoms of stroke, we said that you didn't have a stroke, and therefore you qualify to serve as a control. So it's important to be able to sort of describe how control groups were selected and where you selected the control groups. Did you select your control groups in a hospital setting, or you selected your control groups in a community setting? And are there any differences? So all those must be clearly outlined. I'm not sure many of us write randomized controlled trial papers, but it's one of the most difficult papers to write, randomized controlled trials, because the rigor that is associated with randomized controlled trial papers is so high, because it's believed that that produces the highest level of evidence, of course, after systematic review. So you have to be able to describe how randomization was done, how you kept the randomization sequence, the randomization code, who kept it, and all that. All those have to be described in the materials methods. And then when it comes to outcomes, you must be able to say that your outcomes were pre-specified, particularly with clinical trials. And even when you are doing case control studies, you must be able to tell that this was the outcome that I was looking at. So if you are performing a clinical trial looking at blood pressure control among stroke survivors, and your outcome at month 12 is systolic blood pressure less than 140 millimeters of mercury, that must be pre-specified. And let's say you finish the trial and say, oh, let's increase it to 145 millimeters of mercury because you think your results are going south. No. So your primary and secondary outcome measures must be pre-specified. And the sample size that you use to, the sample size calculation that you use to arrive at your sample size for the study must be presented. And the parameters that you use to calculate the sample size must also be presented, so that it is clear to the reviewer that you are not underpowered to detect or to report the findings that you are going to report. So all these things are important in the methodology session. And fortunately, most of the guidelines that I said, the CONSORT guidelines, the PRISMA guidelines, interestingly, the stroke guidelines, all of them, they give you subtitles that you need to fill or complete within the methodology session. And those must be completed. Otherwise, it will be rejected. And then if there are laboratory methods or techniques that you employed, you have to summarize. So sometimes some of the techniques are quite long. You have to summarize the laboratory methods that you use. So sometimes you measured HbA1c. How was it done? You measured creatinine. How was it done? Or sometimes you measured body mass index. How did you do it? You measured waist circumference. How did you do it? All those things must be reported. And then you have to tell us your units that you measured your outcomes in. So if it's blood pressure, millimeters of mercury, if it is all those things, don't think that the person reading it should know that, oh, as for BMI is kilograms per meter square. If you leave it out, you flag it and tell you that they are missing information. You know, if they want to reject your paper, they can use absence of units to dismiss it. So you don't want to take any chances. Make sure that everything is in there. And sometimes too, if you're using an instrument, let's say the weighing scale, which company produced the weighing scale? Where is it from? Is it from UK? Is it from China? Is it from, you use Omron. Omron, which brand did you use? So all those fine details must be there. Otherwise, sometimes you rock the review on the wrong side. And then importantly too is the description of the statistical methods. This session, I wish that Blay had taken it. He's going to talk to us about the results because he's the biostatistician. Me, I'm a half-baked statistician. I know some part, I don't know some part, but he helps me. But basically, when you're looking at the statistical methods, you want to let us know whether you compared continuous data using standard deviations, means and their standard deviations for variables that are normally distributed, whether you use medians to compare continuous data that are skewed for two groups, and if you have more than 3 groups that you are comparing, analysis of variance, or if you are analysis of variance for means, or Kruskal-Wallis test for comparison of 3 or more medians. The blame, maybe I'm not correcting me when it's your turn. Some of the things I'm saying. And then you also want to compare proportions with chi-square tests. So these are sort of things that when you're writing your paper, it must be clear in the statistical methods. And then sometimes when you want to assess associations, let's say you want to establish an association between hypertension and let's say stroke, you want to report, let's say, odds ratios. And the odds ratios should be reported in the adjusted and then unadjusted with the 95% confidence intervals, and sometimes the p-values must all be reported so that you don't run into problems. And then sometimes you may be interested in reporting outcomes over a period of time. So let's say you have stroke patients that you followed up for, let's say, a year, and some of them suffered events like recurrent stroke, or they died during follow-up. For such an analysis, you may need to specify that you use Kaplan-Meier analysis, and then you followed it up with what we call the Cox proportional regression, Cox-PH, Cox proportional hazards regression analysis, so that you can quantify the effect size of risk factors that are associated with the outcome of interest of, let's say, death or recurrent stroke. So if, for instance, poorly controlled blood pressure among stroke patients is a risk factor for having a recurrent stroke, you want to be able to quantify the effect size by measuring the hazard ratio so that you can report that, oh, when you have hypertension, your hazard for developing a recurrent stroke during follow-up is, let's say, 30% or let's say 50%. And the confidence interval is between so and so. So all those must be well captured in your materials and methods. But because research must be ethically done, within your method session, you must report where you got your IRB approval. Okay. You must report that if you are doing a study in humans, you obtained informed consent. And then some journals will request or require that if somebody wants to look at the data you analyzed, because sometimes a reviewer can say, no, this result, I don't believe it. Send me your data in Excel. Let me also look at it and analyze before I can be convinced. So you have to be able to also say that, well, okay, if the data is required, I'll make it available to so and so through this person's contact. Then you write that. So the overarching objective of your methodology session is to ensure that somebody taking your protocol, the method session, can go through your methods and be able to replicate your study. So I'll end here. I think the results, Leo will report the results. I'll end here with the methods, and then we'll take some questions. Thank you.
Okay, so we do have, let's see. We do have about 10 minutes for questions and answers. So I see Mr. Iroko Davidson. Davidson, go ahead. You are muted. Okay, let's move on to Vida.
Yeah, Prof. One of our challenges is calculating our sample size. So how do you choose which study? Like, how do you decide, or do you need a statistician to do that for you?
My short answer is yes, you need a statistician to do that for you. Because looking back, I've made some mistakes with even sample size calculation for clinical trials, believe it or not. So where I sat in my room, thought that I knew how to calculate sample size. I went to an online calculator, got a value, and then realized I was completely wrong. So you need a guidance of a biostatistician for this. And that is one of the important things to remember, that writing a research or even performing research is not a one-man show. There are expertise that you may need that you don't have. And it is okay to be able to approach a statistician to say that, look, this is a research question that I have. What formula should I use to be able to calculate a sample size? Because I see that a lot of times when people are doing, for instance, a cross-sectional study on stroke, I would use stroke because I read a lot of papers on stroke. Then they will say, oh, the prevalence of stroke in is 1 in 1.4 per thousand. Then they calculate a sample size based on that. And then they get a sample size and then report. But maybe their work is on post-stroke depression. So if you're interested in post-stroke depression, it's not the sample size or the prevalence of stroke that you're interested in. You're interested in the frequency of depression among stroke patients. So you need to get the proportion from literature that have post-stroke depression, let's say 30%. Then you put that formula, that 30% within that formula that you people use. The P is P into brackets 1 minus that formula that you use all the time. That P must be well derived based on the research topic that you are seeking to answer, and not always based on the prevalence of the disease. Unless your study is looking at the prevalence of the disease and you want a sample size to estimate the prevalence of the disease, then you can use that prevalence data. But if your focus is on a specific aspect of the disease and you want to estimate the proportion of individuals with that particular feature or that particular complication or that particular outcome, then you have to sort of use the literature to estimate the proportion so that I can put that in a sample size calculator to give you a value. But having said that, it's always best to talk to a statistician to help you with that. Thank you. Yes.
Okay, so we have Davidson again. Davidson.
Okay. Yeah. Thank you. Thank you so much. Can you please maybe elaborate a bit more on the difference between descriptive cross-sectional study and the analytical cross-sectional study? If you can maybe give an example for the sake of clarity, I'm not able to get the concept really well. If you can please touch on that again for me.
Descriptive cross-sectional study and then analytical. Okay, so typically when we say, so I'm back on this diagram, and that's comparison of group. Was there any comparison of group? Descriptive. So usually under the descriptive study, no comparison. The sort of papers that fall under those categories are usually case reports, case series. Those are usually purely descriptive of, let's say, a surgical procedure that you've done that you want to report on, or you are trying to describe 2 or 3 rare cases that you've seen present in a group. For instance, one descriptive study, I remember, I don't do a lot of case reports, but there was this patient who, when I was doing Borreliosa research, who had pleural effusion. I'd seen hundreds of Borreliosa cases, but I'd never seen a patient who has pleural effusion from Borreliosa disease. So we wrote it up as a case report. So that is usually that descriptive study, an observational study. And then the analytical type, and here I'm sure you're talking specifically about cross-sectional study. So in cross-sectional study, usually it is a large group of people, a reasonably large group of people that you come across at one point or one time point. And sometimes you're interested in assessing the frequency of a characteristic. For example, I want to be able to assess how frequent smoking is among stroke patients. So I'll call or I'll interview, let's say, 100 stroke patients, and then I'll ask them the question, have you smoked before? How often do you smoke? When I finish the survey, I'm going to have, let's say 20 people saying yes, and then 80 people saying no. So when I finish, I'll report that the frequency of smoking among stroke patients is 20%. So that is really a cross-sectional. It's essentially descriptive, because when I finish, I can break up the table into stroke patients who smoke and stroke patients who don't smoke. Are there age differences between those who smoke and those who don't smoke? I'm just describing it. Is there sex difference between those who smoke and those who don't smoke? What is their educational status? Those who smoke, those who don't smoke. What's their income level? Those who smoke, who don't smoke. So when I finish such a study, it's a cross-sectional study. It's largely descriptive, but there's a bit analytical in that I can make comparisons between those who smoke and those who don't smoke. As an example, I don't know whether this is helpful.
Okay, thank you. And we have Gloria.
Hi, Prof. I'd like you to elaborate on specifying your primary and secondary outcome before you even do the study, possibly with an example.
Okay, so okay, so maybe a lot of us don't do clinical trials, but I think clinical trial, this is usually a requirement in clinical trials. And in clinical trials, I'm even supposed to publish your protocol way ahead of time. Okay, so we are currently doing a clinical trial looking at hypertension control among stroke survivors. Our primary outcome is systolic blood pressure control at 12 months. And we are comparing this outcome. We are seeing that our definition of systolic blood pressure control is systolic BP less than 140 millimeters of mercury in clinic. And we'll compare this outcome in those who received the intervention versus those who didn't receive the intervention. Another example, we did a clinical, we've just finished one clinical trial where we're interested in looking at regression of carotid intimal medial thickness on a cardiovascular polypill compared to usual care. So what we did was, at baseline, we'll measure your carotid intimal medial thickness. At month 12, we'll measure your carotid intimal thickness. And then the difference is the rate of change. So that is our primary outcome. And then we'll compare this outcome for those who received the intervention versus those who didn't receive the intervention. So that's, and then our secondary outcomes include things like blood pressure control, lipid control, defined as LDL less than 100 milligram per deciliter. So all those were published, and we haven't even written up the results yet, but all those have been published so that when it is time to publish your work, you don't now say that, oh, I want to change the goalpost and move the systolic BP to this because it's not in line with what, I hope you understand. So you want to pre-specify those things so that it's a guide to your reporting, so that it is rigorous, so that it's not subject to a lot of change. Having said that, that is a requisite for clinical trials. There are some studies that you may do that are largely exploratory in nature, and you may not even know what the primary outcome is going to be like. For example, recently we were interested in looking at how common renin-aldosterone abnormalities are among stroke patients. We didn't know whether it was going to be 10% frequency or 20% frequency. So that will be exploratory. So whatever comes out of that analysis is what you report. That we followed the procedure for measuring renin-aldosterone among stroke survivors with hypertension. And we found that the frequency was, let's say, 30%. But then we had to include control. So in the control group, the frequency was less. And therefore, this is our conclusion. So I don't know whether that helps.
All
yes,
right.
it does. Thank you very much, Prof.
Thank you, Gloria. And I think we are running out of time, but we still have Akofa and Elikem. If you're brief, yeah, if you will be a little brief, because it's time for Dr. Blay to come on. So Akofa, go for it, please.
All right, thank you very much, Prof. My question is a short one. We said earlier that methodology and materials have to be meticulously done. And the reader or the researcher should provide all the necessary information in order for the study to be replicable. My question is, can I take someone's study and decide to replicate it exactly as they've done? And if so, will it be considered as research?
Yeah.
Thank you.
Yes, short answer is yes. You can take somebody's research methods and apply it in a different context and see whether you get the same or different results. An example is what I told you about. The interstroke study used a protocol to assess risk factors for stroke around the world. We used a similar protocol in Ghana and Nigeria, and our results were different because the patient characteristics were different. So yes, you can do that.
But what I meant was in the same population, same sample size.
Yes, it depends on the context of your question. But yes, if, for instance, they followed a certain definition for hypertension, diabetes, dyslipidemia, and the rest, and they're using the same definitions, yes, you can use that.
Okay, all right.
Okay. Elikem, please.
Okay, hello, yeah, thank you, Prof. Hello, yeah, my question is, yeah, it has to do with the sample size. Hello?
Yes, please, we can hear you.
Go ahead.
Sample, yeah, let's say you are trying to assess the impact of particular intervention. Let's say, for instance, the Ghana Health Service, we have what we are doing now as in the holistic assessment. So I want to look at the impact of holistic assessment on the indicators of maybe a panel from health assessment had made any impact indicators. So that how will I settle on this on a sample size that will actually represent the population that I am trying to study about? Hello.
Yes, I think your
That's my question.
I got your question partially. That you want to be able to assess the impact of an intervention, perhaps at a high hierarchical level, let's say at a health
District level.
Or district, yes.
Yes. So I want to find out from health workers at that district level, at the district level, how the intervention has impacted on their indicators.
So sometimes, say you want to find out whether it has improved their level of competency or knowledge in maybe administering a certain intervention X. Sometimes
yes.
you may do a before and after study. So before, what their level of competency or knowledge? After the intervention, what was the level of competency and knowledge? And then say, okay, it increased by 20%. But before the intervention, you might not know this, that it will increase by 20%. So you either read around the literature and say, okay, when people have done this sort of intervention elsewhere, the effect size that they observed was, let's say, 50%. I will go with a conservative figure of, let's say, 40% in my setting, and then calculate a sample size based on that conservative estimate. And then that will give you the sample size that you need to be able to test that intervention.
Okay.
Yeah, thank you.
Yeah, AfriCMR, sorry, we've run out of time, but Prof will come back after Dr. Blaze's presentation on the results. So you can write down your questions when he comes back to do the discussion. You have the opportunity to do so, to ask him questions. And also Mabel, the same thing. When he comes back, you'll be able to ask questions. Okay, thank you. Now, Dr. Blaze, Ingwa, you are on. And please,